Good morning, everyone. Lovely to be here. And apologies that I have got a nasal voice today, but hopefully it won't distract you too much. So I'm going to be talking to you about positive approaches to reduce stigma. And I think we talk about stigma a lot, and it's a word that is in our vocabulary a lot. But I think as healthcare professionals reflecting on this together, I just want us to think about three key questions. And I always say that we also are part of the groups that could be stigmatized, and I kind of give a trigger warning because a lot of the things that we talk about are also reflective in our lives as well. Also, apologies, I must do my disclosures. So, speaker fees, medical director at Preventex, and medical board at NAS. So, do you feel respected? And I'm not going to do hands up, etc., but just for reflections, because I know that can feel painful. So do you feel respected? Do you feel protected? And do you feel valued? And I call this the RPV factor because there are many people that we will live and work with and care for that for many of these answers or all of these answers, the answers will be no. And often when we think about the RPV factor, it can also be seen as experiencing rejection, prejudice, and vulnerability as well. And when we want to define stigma, there are many descriptors of it, but the main descriptor is a mark of disgrace associated with a particular circumstance, quality, or person. And essentially what it does is that it distinguishes people based on social statuses, such as attributes, illnesses, and their identities. And it's that social devaluation, discrediting that others have mentioned earlier, and excluding individuals with those statuses. And the key thing about it as well is that it is a really complex, but it's a social phenomenon. It's not one aspect of a person and one individual, and it's perpetuated in one individual. It is a social phenomenon affected by many, many people. And so stigma itself is a form of prejudice, and it manifests in degrading communication and attitudes, and then it degrades the stigmatized person. And shame is the emotional manifestation of this. And again, I'm really emphasizing this here because when we think about the approaches that we have to stigma, we've got to see how deep it goes and these deep emotions that they evoke. And so, as you would imagine, it negatively affects a person's sense of self, but also has severe consequences on their physical and mental health. We also recognise that HIV, unfortunately, remains highly stigmatised and also misunderstood. But stigma really undermines all we do within the HIV sector. And I think, again, in Susan's slide, when she was talking about the things that need to be addressed, stigma came high on the list because it is the thing that drives everything that we do. And it's definitely a clear social justice issue. And again, when thinking about stigma, we need to think about all the different levels at which it operates at. Interpersonal, internalized, institutional, whether it's experienced, whether it's perceived. And that aspect of perceived stigma is so important. You may not feel that you are stigmatizing someone, but someone, whether based on their previous experiences with you or someone else, may perceive that your behavior is stigmatizing, and that in itself is unacceptable. And when we think about the layers of stigma, I think one of the most stigmatizing things in the UK, and I do quite a bit of work in Ghana, and I'm more recognizing it day in, day out, is class in the UK. And I think that's one of the most stigmatizing aspects of a person's identity. And when you're thinking about stigma, just recognizing this intersecting, overlapping layers to an individual's identity that all determine whether someone's stigmatized, how deeply they're stigmatized, and how often they are stigmatized, and in what setting as well. And Also recognising that people living with HIV will encounter intersectional stigma, but the frustrating thing, again, as has been mentioned earlier, is that HIV can often be the smallest thing in their lives, and everything else driving it really perpetuates that stigma even more. One of the good things is that we are recognising stigma more and more in our targets and our international, national, local approaches, and that can't be underestimated, because the level of stigma that's experienced isn't always reflected in the policies and processes that may be within the HIV sector, but other sectors as well. And so within the UNAIDS target, we have got the target of less than 10% of people experiencing stigma and discrimination. But I'm sure, as many of you will be thinking, as I think, is how do you measure that? You know, where does that 10% come from? So we have a multifaceted problem, and it needs multifaceted solutions, and it requires understanding, measuring and mitigating stigma across many levels. So I often talk about the 4 A's of health equity, and I think it really applies to tackling stigma. You've got to acknowledge your inequalities, you've got to advocate for those affected, you've got to amplify the message of inequalities and the need to address them, and then you've got to activate those who are affected by it. And again, if you are thinking about stigma, it falls in those domains very much. So I'm going to use the Fast Track Cities model, Fast Track Cities London model, in terms of their process of thinking in tackling stigma. And it's a framework, and I'll be using other examples, so I'm not totally biased, but I do think the structured approach to it is really powerful. So we have Fast Track Cities London, we have, and there are many Fast Track cities, so again, declaring that. And but we know that the City of London has made the commitment clear to be the first city globally to get it to zero. And within that, there's a focus on stigma. So it's spearheaded. What I think is crucial is a systematic and collaborative approach to tackling stigma, and recognising that you need impactful interventions, but you need to understand where we're starting from to co-design these interventions. So it was acknowledged that they needed a dedicated action plan, and it brought together a team of individuals, which I was fortunate to be a part of, to review the data evidence to date and think about the path to ending stigma. And it recognised 3 levels of stigma that they wanted to work on. So societal stigma, commissioning a survey to set a baseline of public knowledge and attitudes, internalised stigma, so creating an empowerment programme shaped by community of practice, and targeting stigma in the NHS and other public services. And I think this is particularly relevant as well, as our colleague from Brent was highlighting, that you know, there are many people that are people living with HIV will be interacting with in social services, and they are the ones that also particularly need to be educated to eradicate stigma for people wherever they go. So looking at the survey, first of all, and I'm just going to give an overview, but this was commissioned by Fast Track Cities with National AIDS Trust, and it was implemented by Britain Thinks, an organisation. And again, it looked at public perceptions and knowledge in the UK. And I'm sure many of you have heard the highlights of it, but I think it's a worthy reminder, because it's just recognising the challenges that we still face. So, and I'm going to skim over these, but over 6 in 10 report not having heard anything about HIV in the last 6 months. Only 1/3 of Londoners say they have sympathy for people living with HIV, regardless of how they acquired it. I'm often cautious with the term sympathy, but I think the notion is that that empathy that's required isn't there. And then also it was emphasised, what I've said is that the HIV stigma was complex, but 3 key themes came out. So acquiring HIV is associated with taboo behaviours, there's a low level of knowledge of transmission and treatment outcomes, and there's negative attitudes towards the LGBTQ community who are closely associated with HIV. And there have been additional insights from local services. So colleagues at Barts and King's College have put together stigma surveys to explore experiences within their settings. We've also had the European survey as well, all giving us the insight that we need to think about what do we need to do next. And one of the things that came out really specifically was that people hadn't heard about HIV in the last 6 months. So it really highlighted the need for mainstream representation. So again, another positive approach. So we've looked at a survey, we're then thinking, what is the mainstream representation that we have? And I actually should have put here, apologies, the Scottish advert with Terence Higgins Trust, which if you haven't seen is really fantastic. So again, it's getting it out in the local media and national media, but what we have to recognise is that it isn't just about ignorance and lack of knowledge. Stigma and the resulting shame is derived from judgments, it's derived from assessments, individual appraisals, and that's determined by people's values and behaviours. And so it requires deep penetration of those values and behaviours to see a change. But the media is crucial in this. But what's important as well is that the mass media needs to be clear and it needs to be consistent. And if we ever saw that failing, we saw that in COVID. And so we know we've lived it. And there needs to be a concerted partnership with this messaging across media, across faith institutions, across workplaces to really cause a shift in stigma. Another aspect of stigma, and I'm giving specific overviews, is about self-stigma and the notion of an individual being affected by all the negative judgments and appraisals, that it becomes internalized and affects who they are and, as I've said, their sense of self. And so in response, the Fast Track Cities with 6 organisations, am I lying? Sorry. Really particular about numbers, is 8 organisations, came together to form a community of practice. And then they focused on developing a framework of how do you empower individuals. Because I don't know about everyone here, but I always feel cautious about always asking people that are affected, that are marginalised, to then do the work of educating people. But on the same token, there is power in visibility and representation, and not everyone has the confidence to be out there talking about their lived experience. So how do you support that? And this community of practice really worked to develop guidelines and a framework. And then as a result, 6 community organisations have been commissioned to deliver specific empowerment programmes. And I know that, for instance, in East London, colleagues in Positive East have focused their work on women of Black African origin. So changing societal and organisational stigma, and within this, again, building up the empowerment work is the ambassador programme. So another positive approach. And within this ambassador programme, Fast Track Cities are working with the Terence Higgins Trust to identify ambassadors and to recruit and train people living with HIV to share their personal experience and highlight and eliminate HIV stigma. And it's all about educating different parts of the health and social care system and other organisations, including nursing homes and other frontline services. And again, as clinicians working together in these spaces, sometimes we see some of our patients and that we think that actually could be great at this. And what's really important is that we be aware of all the programs that are out there to not only inform them about what's happening to support stigma, but also if there are things that they want to get involved in as well. And something that is also really exciting is the HIV-friendly charter mark. And, you know, we have disability confident, we have other charter marks which I think work really well to raise awareness about certain conditions and lived experiences. And we have the HIV-friendly charter mark, which is formed and developed with Fast Track Cities, National AIDS Trust, NAM and Positive UK. And this, and I'll give a personal reflection, so in Barts, colleagues, Moses, one of the nurses, disseminated a stigma survey amongst colleagues, and sadly, but unsurprisingly, we saw high rates of lack of knowledge of HIV, but stigmatizing thoughts as well. And so we're really looking forward to working with the team, and Gary Bruff, who's leading it, to really work with our chief executive and then all our staff groups to raise awareness about HIV, and also encourage people, staff members that are living with HIV, to know that they are seen and valued, and that we are working to make sure that there is zero tolerance for discrimination. But also for all the patients that we see, you know, there's many things that hurts me in life, but one of the things that can be really deep is when you have someone come to you and then they tell you about a negative experience they've had elsewhere in the healthcare setting, and it's, you know, it's shameful. And it depends your personality. I'm the type of person that will go and contact that individual and do that, but it's system change that is really required. I was really happy to hear Laura mention about peer support, because I think in challenging stigma, again, local experience, having a dedicated peer support worker within our service has been transformative. But I really do believe that there requires integrated peers in all we do, and there needs to be more work to enable peers to do more than they are doing, and equipping them with the educational resources, the kind of legitimacy within our services to enable them to support in more ways than actually we can. And so that's another approach to, I believe, to challenging stigma within our settings. I put this slide up there, and it is quite a busy slide, but it's something that I think as healthcare professionals that we really need to think about more. And it's got a number of concepts within it, and it's actually taken from the National Collaborating Centre for Aboriginal Health in Canada. But it really makes us think about the type of care that we are delivering, but also challenging us in our own personal mindsets and thought processes about us as individuals, us within the wider system. What can we do to make sure that every individual feels safe within our services? And this concept of cultural safety, I'll pick out one of the key things is about cultural humility. So we talk about cultural competence and understanding and recognizing that someone is from a certain lived experience. So someone will see me and they'll be like, right, this is a black woman, she's second generation, so she's lived in the UK all her life, but she must have other family and influences elsewhere. And then you can make other judgments about my education, class, etc. But that snapshot isn't just me, because then you will see me 6 months, a year later, and my life has changed. All our lives have changed in many ways. So having cultural humility recognises that appraisal and reflection of someone needs to be a constant thing that we do in our interactions and our reflections of self, our reflections of our colleagues, and also everyone that we care for. So having a sense of cultural humility. And also, the other thing just to pick out from here is about trauma-informed care. So recognising that the individual that you see in front of you, stigma and experiencing stigma is a trauma. And, you know, whether you've experienced it once, whether you've experienced it day in, day out, it is draining. And it manifests in ways that you don't even realise. And so even just acknowledging it and saying that we're going to think about how is that rooting and impacting your engagement in care, your adherence, your mood that day is really important. And I think this concept is something that really enables people to then feel safe when they interact with others. I always have to put a plug out to wonderful colleagues, but I think that if you haven't heard, I'm shocked, and you need to hear about it, that our Stories Told by Us, which has been curated by fantastic women that have been key in the HIV response, have brought together stories and voices that haven't always been heard. And that is crucial in challenging stigma. And I think that it's within our sector, but we need to get it out there more, because these stories need to be shared and heard. I just wanted to end on these slides about the fact that, and again, it's picking up on something that Laura said, you know, as a sector, we do well, we can always do better, but it isn't just our responsibility. That we are part of a very big system, a very global system. And one of the things that is really important is that we make other services and other people accountable. So even if we feel that we are doing and challenging stigma within our settings, we need to voice when we see unacceptable behaviour. We need to voice when we see things that need to be changed, such as in the insurance industry. And I know that that often can feel tiresome. You know, we're trying to see patients, we're trying to deliver the best care. But I think that if we can collaborate and even, you know, we've got organisations at Beaver that are ready to do the work for us and amplify and push things forward. But we need to, as a sector, ensure that the response to stigma isn't a HIV response, but it's a multi-sectoral response. When I talk to colleagues in other sectors, I talk about five things, that if it feels that it's a lot of work to do, then just think about these 5 things that you can do as an individual. Be informed. Have a conversation, use people first language, shout out to Laura, normalise testing and treatment, and recognise self-stigma and action stigma, and just give that voice and awareness. So I'm just going to leave there because I'm sure I've overrun and everyone's smiling politely at me. So we'll go on there. So thank you so much.